Hi, welcome to Mad Medicine with Miss P. Some fun stuff today, a little bit anyway. I have a question, I guess. Oh, you know what? Let me first concede that, okay, pain can be a verb to an extent. I was watching a video, kind of as a slap in the face, I guess, because that's the way the world works. And the little video lady, the little YouTuber, she actually said, it pains me to say this and this and this. I thought, crap. Okay, so I will concede that pain can be a verb when used correctly, but it's been paining me, even if that is possibly correct. It still is painful to hear. It's never going to be one of those things that sound correct. So I just wanted to clear that up for anybody, for the six of you watching who may want to argue with that last one, and that's fine. Okay, here's the other thing. As I say before, I do. We do a lot of pain procedures or pain control procedures. Like epidurals and radiofrequency ablations, medial branch blocks. And my partner and I, when we're in the room together, she knows it drives me insane because it doesn't matter how many times you say, unless someone's had multiple epidurals, they roll in onto a stretcher next to the procedure bed that, has the big C arm right next to it, right? And I say to their face, touching them, it's not like that there's any misunderstanding. And I say to them, roll over onto this bed, and I tap the bed. And they scooch over while still on their back. I know I've brought this up before, but because it happens every week, I don't understand the miscommunication. First of all, you have back pain and you're going to get an injection in your back. You've already signed the consent. Surely you recognize that we need to get to your back. We cannot go through your abdomen to get to your epidural space. I mean, I guess you could, but we're not doing that. There's a lot of organs and stuff in the way. So when I say roll over, you realize that doesn't mean scooch over or shimmy over or slide over. We say the words roll over, and every time, I have 4 out of like 16 the other day, 4 that I tap the bed and say roll over, and they shimmy over onto their back, and now they have to like do this weird like attempt to turn on this narrow bed while having this horrible back pain. I don't understand what the lack of communication is. Okay, and then the other thing I was just going to mention, last week I said there was 2 funnies, but I didn't want to get into it, so I just kind of skipped it in case you're wondering why I so weirdly left that, like just ignored it. The charting, oh my God, my boss is having me do some chart review. When we get really behind and I've got free time, she'll just give me a big stack of charts and we'll just, go through them and review. It's a little checklist, and you kind of have no choice but to read some of the nurses' charts, the notes, because you have to verify that, this was done or that was done. And I believe someone actually wrote that they give 1 milliliter of Solu-Cortef. That's not a dose. And I couldn't even tell whose handwriting it was, or, I mean, not that it matters because there's nothing I can do about it, but nurses, you recognize medications come in milligrams, grams, micrograms, units. You can't give a milliliter of a medication. Lactated ringers, because it's a solution, can be given in a milliliter. But we said this before, like whether it's Cardizem or heparin or Dig or amiodarone, those all have units of measures, and it's not milliliters or drops or anything like that. You have to know how much medication the patient's getting, just like the orders will coincide, will reflect how much medication. Now, the concentration of the solution or how it's given, that's how you may titrate it to how many milliliters, but it's about the amount of medication. And to see that this nurse thought that Solu-Cortef comes in milliliters, that's not a dose. It was probably 125 milligrams most likely, and that makes me very nervous. And it was an old chart, so it's the patient's fine obviously, but I don't understand how you get this far and don't know that medications have to be measured in a specific unit so you understand how much they got. And you can put 5 milligrams in a milliliter, and you can put 300 milligrams in a milliliter. So milliliter, that's not a dose. It's not a dose. Okay. Oh, a patient did tell me that she gets the anti-reflexes from taking aspirin. She has the anti-reflexes. Are you saying anaphylaxis? Okay, so anaphylaxis is not a reflex, and it certainly isn't anti-reflexing. It's an allergic response. Anti-reflexes with aspirin and NSAIDs. That's because aspirin is an NSAID. So just say NSAIDs. I don't understand. Another, my coworker told me that her patient says she takes the Z-Pak for sleep apnea. Maybe she has a pulmonary infection and she's currently on Z-Pak, so she doesn't stop breathing. I don't know. Z-Pak for sleep apnea. That was precious. Oh, she also told me that the patient takes metformin for AFib. I can't. I'm not expecting any patient to be a chemist, a nurse, a pharmacology professor, but there's got to be a little tiny, like even my mom, who is really kind of naive about this sort of thing, she just kind of trusted or told me, like she kept the insert from the pharmacist and she even read it, which, I mean, she was just a very, very smart person. So that's all it takes. You don't have to have any, I mean, she was brilliant in so many different aspects. I mean, that woman, she was just so sharp, so sharp. So, surely this patient doesn't think they take metformin for AFib because, oh, and that leads me to I'll go ahead and go into this because this other thing drives me crazy. One of the YouTube, I want to say it was a YouTuber, maybe it was that V-Shred guy, and I'm sure everybody in his industry hates him and he's a big dork and what he does isn't real, but oh my God, he is so beautiful. His name is Vince. I know you guys have seen him. He talks about your body type quiz and take this quiz and, cutting your carbs ain't how you lose weight and you don't have to, work out like a lunatic and stuff. And he is so pretty. Sometimes I just mute it and I just watch him. I just watch him. He's so pretty. Anyway, I don't know if it was on one of those videos or one, even maybe it would have been a YouTube video where like someone I can't remember. So anyways, somebody died from diabetes. That's not really how diabetes works. And I can't figure out why people don't understand diabetes. It's really not that tricky. I had a patient the other day, we were talking about, she was so good, so sharp, and she was just on top of it. And she'd just been diagnosed and she had a couple other issues, and maybe one day we'll get into it. And as she was telling me, I kind of explained to her what's going on in her life, that she had all these things happen to her. And she's kind of looking at me like, why do you know that? Because her disease, her dis-ease that she was explaining to me was very obvious, what mental, emotional issues she was going through. And it was really interesting. And she was a scrawny little thing with diabetes. Often you think that, oh, if you have diabetes, then you're, morbidly obese. And that's not always the case. It's a different situation. Long dull story. Anyway, to die from diabetes, you either have to be in diabetic ketoacidosis or insulin shock. You're one of the two. You either have to go into hypoglycemia, so much so that your organs and your systems completely shut down because there's no fuel that they're able to continue to work, just like anything else. Like if you stopped oxygen intake, you would die. Same difference, right? But like dying from diabetes, that's not what you can have diabetes for 30 years. My stepmother, she has had diabetes as long as she's been with as long as I can remember. She's 20 years old when she got with my father. She had diabetes then, and she has it now, and she still has her toes, her eyesight, her kidneys. I mean, some of it might not be doing as well as it used to, but because she pays attention to her sugars and she takes care of it, you can have it forever and live happily ever after and die of a completely different thing. You don't die from diabetes. You die from poor control of diabetes. And some patients, and I've said this in the past, that are very difficult or very brittle, that's a different story. And, they could have other issues, but you don't have to be on dialysis just because you're diabetic. That's not the way that works. In some cases that are very severe, it may lead to that, but you don't die from diabetes. it's kind of like when you hear about a homicide, there's a manner in the manner of death, and then there's the cause of death. And it's really interesting to see the difference, because if they're like, oh, they died from head trauma, right? That's the manner of death. Someone hit them in the head with something. But what was the cause? Did they have an internal hemorrhage in their brain that, shut down brain function? There still has to be a reason. So you don't necessarily die from diabetes. You die from either poor control that allowed your blood sugar to get way too high or way too low that caused these specific issues, or you've had it uncontrolled for so long that other organs, other systems shut down and cause an issue. But every time I hear that, I'm like, no, that's, like even he died of heart disease. Okay, he probably had heart disease when he died, but there's still a reason that if that last beat pumped for a reason. What caused that last beat? Was it a clot, an occlusion in the coronary arteries? Was it a freeze in the electrical system? A cardiac arrest? There's a reason. You can't just be like, oh yeah, it's heart disease. That like, oh, you died in a car accident. Right, that was the manner, but what actually caused bodily harm that stopped the beating, that stopped the breathing? There has to be a reason. Another person, and some of this I just delete. I don't want to read any more that morning of surgery to get this person ready that I don't have to read, especially if it doesn't matter to all these people. It's almost like they want diseases. Or maybe they feel like no matter how minute it was, it's worth mentioning, which is legit. They probably should feel that way, because some things that they think are nothing are huge, and they're like, oh, should I not mention that? But this person had some palpitations 6 years ago and was like totally cleared, and they found nothing, cardiac related. There's none of, don't care. That's not even worth mentioning at all. So needless to say, I read it, I'm aware, I deleted and put in there, skip the no cardiac issues. I don't, palpitations, I have palpitations regularly. That does not mean anything's wrong with my heart. When you can feel your heart beating, there's a reason for that, but it's generally very benign. And one day I'll go have it worked up and find out what's wrong with my heart, because I'm sure my son, trying to break it the last 10 years, it may have some effect on it, but right now I'm pretty sure it's beating just fine. Also in the list of surgeries, this person wrote vaginal delivery under surgery. That's, even if you had an episiotomy, that's still not surgery. I mean, it's a cut and it's a sew, but again, maybe they just feel like they, after you go through it, it's probably much bigger than your average surgery. I wouldn't know. I've never pushed a human out of that tiny, tiny, tiny little hole. Scares me to death. The fact that that's even a normal thing to do just blows my mind. And it is the best, healthiest, greatest thing you should do, could do, but I'm not doing it. I didn't do it. I thought I was going to do it. Thank God I didn't have to twice. Yeah, it's crazy. And under surgery, also another person wrote stage 4 neck cancer. That's not a surgery. I don't even know what surgery that would be. Are you talking about we had like some sort of excision, a major resection? Stage 4 neck cancer, not a surgery. I don't even know what kind of cancer that's. I don't know. The other, another person thought they had a breast biopsy under a block. What block do you suppose would not let them feel their chest but not paralyze their diaphragm? Where exactly does that start and stop, do you think? That's probably not a thing. Oh, and then I heard a sweet little anesthesiologist at the desk. I saw it and I just kind of ignored it. But I hear him real quick. He's very soft-spoken, sweet guy. And he goes, oh, liver transplant under an epidural. Yeah, I don't think that happened. Just real nonchalant. Yeah, probably not. They have no idea. Like I said, it's not their fault. It shouldn't even be in there. There's no reason for it to be in there. They have no idea. We know what kind of anesthesia it most likely needed. There's no reason that they would have to guess. It's almost like, let's set them up to trap them to see how dumb they are in this particular subject, which is not even fair. It's, and a lot of times I don't even know. So I'm thinking like a cardiac cath. I don't think that would be general, I think that could be sedation. I mean, they can go through your wrist or your groin. I'm like, I don't know. I'm not in the cath lab. I have no idea. How could they possibly know? But still precious. And then the last one on here. Okay, so I wanted to clear another little thing up because it didn't dawn on me until a coworker mentioned that she had some swelling in her legs, and she didn't have, she has no renal history or anything like that. Young, healthy, active girl. So her, it's not even her internist, it's her kind of natural holistic lady. I want to go see her, and one day I'm totally going to. She sounds like she and I would be best friends forever. She had mentioned, she said something like, oh, well, do you have low protein? And I was like, oh my gosh, of course. And I didn't even think to mention that when we talk about renal failure or CHF, that you can have swelling in your feet or, a dependent area, and it doesn't have to be directly kidney related 100% of the time, but most of the time it is. Otherwise, why wouldn't your kidneys be messing with that? The true other possibility or option or reasonable explanation, and the only reason I figured this out, and I didn't even figure it was fed to me, is my mare, and this is the story I explained to my coworker. My mare at the time, who was maybe 3 or 4 years old or something, healthy, active, beautiful, gorgeous, awesome horse. I bring her in, and her feet are like, her legs are really swollen. And I brought her in from being outside. And the best way to stop someone being stocked up or having fluid in their feet is you put them out and they walk around, and your circulation moves, and your kidneys move, and everything is gone. But she came in like that, and I was like, what's going on? And I call her my Hoover. So I put her in the other stalls of spoiled rotten brats who I've had since birth. And they have been fed so well that, they'll leave this or they'll leave a little of that. So I put her in there, and she cleans everything up and, makes the stall easier to clean, all the hay. And she'll lick the bucket clean and find little feed in the corners that, the other spoiled horses leave. So I just, put her in there, and she hoovers the place up. Well, I may have done that possibly multiple times, and she may have gotten too much magnesium. Some of the other horses leave their magnesium behind, and I'm assuming that's what it was. Like I said, it was years ago, and I really can't remember, but I remember she had a bout of really severe diarrhea. So I'm calling my vet friend in South Florida, and I'm, kind of explaining this to her, and she's like, well, she probably has low protein. I'm like, she can't have low protein. She gets like 2 pads of alfalfa a day, and I give alfalfa pellets and all this. And she's like, no, dummy, you're not feeding her low protein. She has low protein in her bloodstream. And as she told me this, I was like, well, how did that happen? Or I don't get it. Then, like, not a few days later or so, maybe a week later, whatever, I'm teaching the IV therapy course. And as I'm talking about osmolarity and stuff, and we're talking about colloids, versus isotonic solution, hypotonic solution, hypertonic solution, and colloids and how they work, I went like, oh my gosh, of course. She managed to lose so many particles, protein related, meaning protein is what kind of stays, or colloids that stay in the vasculature that allows the kidneys and the vasculature to properly move and shift fluid in and out of those of the vascular walls at the capillary level, that distal and conic pressure we're always talking about. So if you have such low osmolarity, that fluid is going to be forced out of it. You're basically hypotonic. So you don't have enough particles and fluid to even out. So you have less particles and more fluid. So my hands always look huge when I do that. Look how big my hands are. Oh, giant lady, man hands. So if you don't have enough particles in the bloodstream, then that fluid is like, well, crap, I got to get rid of this fluid. Well, where's it going to go? It's going to push it out of the vasculature into the cells, into the interstitial tissue, just out, so it's not fluid overloading the circulation and causing hypertension, all kinds of other stuff. And I thought, oh my gosh. And right then and there in front of the whole class, I was like, that's why my mare's legs are swollen. And of course, it balanced out on its own. I didn't have to do anything to it. It just kind of took care of itself. But I thought, you idiot, you teach this. And of course, when it's home, you never think about it. Like if you were in an emergency situation out in public, you turn them on their side and, clear the airway and Annie, and are you okay? But it's your daughter at home. You're like, ah, you just freak out because it's your baby and you can't think when it's your own horse. Like I've had a horse come in and they're swollen, they have all these issues, and then like later in bed, I'm thinking, why didn't you give them some butch, you idiot? You panic and you think about all these things, but you don't think about the right thing. So I'm assuming that that's what happened, or I'm just an idiot. So you can have like a osmolarity, protein shift, low protein, low particle vasculature issue, which would cause fluid to shift out. Now, this particular friend of mine, the coworker, was talking about, her hormones, and, her internist, her doctor friend was saying that, it could be hormone related. And I was like, okay, you got to let me know on that. I got to know how your hormones could cause that. I'm sure it could. I just don't know how or why. And if you know me, I got to know, like, have we met? I need to know. Like that has to explain it to me like I'm a child, make it make sense. I need to know. So that's it. I just thought I wanted to clear that up because I'm always like, it's kidney failure, it's kidney failure, it's kidney failure. Oh, your toe hurts, it's kidney failure. Oh, you got swelling, it's kidney failure. And most of the time it really is. I mean, honestly, it really is. But when someone said my GFR is totally normal, my BU and creatinine are fine, I've never had a kidney issue, it very well could be a low protein osmolarity issue, and I just never really thought that, because 99.9% of the time when we're talking about CHF, it's uncontrolled hypertension, pressure clean the kidneys aren't working, you got excess fluid, you take a diuretic, you take a cardiotonic, you take a antihypertensive, and that's the cycle that, the hose, the pump, the fluid, that's what we're trying to correct. So, okay, so that's it. Same as always, face your fears, forget your failures, follow your faith, and if I think of anything for next week, because I really don't have anything, I'll see ya. Otherwise, I got nothing, and I'll see you when I see ya. Okay, love you. Bye.